Okay, esophageal rupture or esophageal perforation is a very, very dangerous thing that can happen, and the biggest risk factors for this is esophageal instrumentation. The patient can present with chest pain, fever, and on x-ray you will see a widened mediastinum. Instrumentation, again, is one of the biggest risk factors and trauma to the area, but also if patients have extra effort, it can cause rupture. For example, patients who throw up a lot and have Boerhaave syndrome. Also esophagitis. If the patient has infectious esophagitis, they can also have pill esophagitis from having too much medication, and also caustic esophagitis if they were to drink something that was very corrosive to the mucosa. Because the esophagus is located more posteriorly, the patients can also have back pain instead of chest pain. On auscultation, if you put your stethoscope on their chest, you might have an Hamann sign, and the Hamann sign is when you hear some crunching noises. A very small percentage, but you can hear crepitus sometimes if the patient has subcutaneous emphysema. And I know I mentioned a widened mediastinum on x-ray, but also on the thorax area, the patient can also suffer from a pneumothorax or even a pleural effusion. If it's an emergent situation, then you should get an x-ray or a CT scan. On chest x-ray, again, widened mediastinum, you can have a pneumomediastinum, a pneumothorax, or a pleural effusion. If you choose to do the CT scan, you'll see the esophagus wall thickening and you'll see mediastinal fluid collections. The gold standard for diagnosis should be the esophagography or the CT scan using water-soluble contrast. Second line diagnosis should be with barium contrast. It's much more sensitive, but because the contrast itself can cause inflammatory granulomatous responses, you have to try to use water-soluble contrast if you can. In the end, the management would be emergency surgical consultation, and also you want to have the patient NPO. They can't eat anything. You give them antibiotics, especially if they have a fever, and give them proton pump inhibitors. Don't forget to also get an EKG because this can present as a heart attack. However, if the patient's having a fever or some back pain, it's a lot less likely. Also, you can be thinking about an aortic dissection, but remember that this aortic dissection can often cause a new aortic regurgitation murmur, and also you have that asymmetric blood pressure between the upper extremities and the lower extremities. Also, again, the patient is presenting with a fever, and they also may have had a recent instrumentation, which makes esophageal perforation much more likely. Do not pick upper endoscopy to rule this out because this would also include insufflation into the area, and the instrumentation can worsen the injury.